This is a patient of posterior cataract. She was having the posterior cataract in the visual axis, which was disturbing her vision and was hampering her studies. Side port is made, the axis was initiated. As the cortex was soft, the rexus margin was trying to move towards the equator. I tried to pull it towards the center, and somehow I could regain the rexus margin again towards the center. You can see as the capsule is elastic, it tries to move towards the equator. So our first take home message in this patient is, when the cortex is soft, try to do a rexus small so that it remains in the center and does not go out towards the equator. The rexus was complete, though not circular, was a little oval towards the temporal side. The main incision was made by 2.8 millimeter keratome. And normally I try to go inside in the AC, dipping inside in the AC and trying to make my wound, the internal wound, a little larger than the external wound, so that the maneuveration of the phaco probe inside becomes a little more easier. A controlled gentle hydrodissection was initiated in all sides with just to separate the cortex from the capsule, not going enough towards the posterior side, a little on the anterior and towards the equator, so that the movement becomes easier and it comes more easier to the phaco aspiration. Now, phaco aspiration was done mostly and without or very less phaco energy was used in this patient. All of the cortex was so soft that it came out with aspiration. You can see here the most of the I don't even use my second instrument most of the time. So when there was a little of required, I tried to pull the cortex towards the phaco tip and it was aspirated easily. All around, I just wanted to remove the cortex all around, so, and the plug to remove, the posterior plug to remove in the later part, so that if there is any defect, posterior capsular defect does not come out in the initial part, and so I wanted to disturb it towards the end after the removal of the cortex. So now this is the cortex been removed from the inferior part, and I could see that there was a little of movement of the plaque and it didn't show any vitreous disturbances or any defect in the posterior capsule. So I tried to remove the plaque also. Yeah, the plaque also came out and it was aspirated with a little of energy used at this time. Now the AC was maintained with the fluid and the phaco probe was removed and viscoelastic was injected. The cortex left behind in the subincisional part was removed by the Simcoe cannula, which is very comfortable instrument in my hands. I tried to remove it with Simcoe cannula as because the large amount of cortex comes out easily with Simcoe, and the movement of the Simcoe cannula is really easier at times, and at certain times I even use my bimanual irrigation aspiration cannula also. So the wound is little extended so that the injector does not give much of a stress on the incision site during the injection. The phaco incision, the hydrophobic intraocular lens has been injected in this patient. The lower haptic goes inside the bag and the upper haptic, as I was trying, but it was not in the bag, so I tried to dial the upper haptic, which was dialed in the bag with a dialer. Now the viscoelastic behind the lens and anterior to the lens was removed by the Simcoe cannula. All the viscoelastic removal is very important in the post, so that the post-op rise of the pressure is avoided. The viscoelastic is removed from all the quadrants as well as from the angles, and the wounds are hydrated properly, and the AC is well maintained. The case is complete. Thank you. Thank you so much for watching.